بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Hi everyone. In the previous two lectures, we had studied iron disorders either in the form of deficiency or overload. Today we will study the disorders of the iron partner, the protoporphyrin. These disorders include defects in the early pathway of protoporphyrin synthesis in the form of citroplastic anemia, and defect in the rest of the pathway leading to porphyria. Citroplastic anemia occurred due to a defect in the interaction between glycine and succinyl-CoA to form delta aminolevulinic acid. In the presence of the delta aminolevulinic acid synthase enzyme, which is abbreviated as ALA synthase. Here, there is a defect in the ALA synthase enzyme or its cofactor pyridoxine. The defect prevents this reaction and interrupts the synthesis of protoporphyrin. Here, there is no defect in iron and its metabolism. Iron is uptaken by normoblasts and enter the mitochondria, but now it finds no protoporphyrin to incorporate with, leading to its precipitation in the mitochondria, which causes damage of the mitochondria, leading to further deficiency of the ALA synthase, and so on. From here comes the name of the disease, sideroblastic anemia, as it is characterized by iron deposition in the mitochondria of sideroblasts. As the mitochondria is normally distributed around the nucleus of the normoblasts, iron, when deposited in the mitochondria, it will be distributed around the nucleus in the form of a ring, as shown in front of you, leading to what's called ring sideroblasts. Sideroblastic anemia is a group of refractory anemias caused by blockage of heme synthesis due to a defect in the pathway of protoporphyrin synthesis. Refractory anemias means anemia which don't respond to hematinics. Here are the causes of sideroblastic anemia. Causes are divided into hereditary and acquired causes. The acquired causes is more common. Hereditary causes are divided into X-linked, mitochondrial, and autosomal causes. The ALA synthase gene is carried on the X chromosome. We said that the most common hereditary cause is a defect in the ALA synthase enzyme. Thus, its inheritance is X-linked and is called X-linked sideroblastic anemia, which is sometimes accompanied by ataxia. Sometimes the defect is in the mitochondrial DNA in the form of duplication or deletion. These defects will depend on the number of mitochondria in every cell. This occurs in syndromes called Pearson syndrome, Kearns-Sayre syndrome, mitochondrial myopathy, lactic acidosis, and sideroblastic anemia syndrome. The hereditary defect may be autosomal, as the thymine-responsive megaloblastic anemia or dead mood syndrome, which is characterized by DI, the diabetes insipidus, DM, diabetes mellitus, O is optic atrophy, and D is deafness. Also, the defect may be in the ferrochelatase enzyme or in the glutadoxin gene, which is responsible for mitochondrial transport of glycine. The acquired causes are more common. They are divided into primary and secondary causes. The primary sideroblastic anemia occurs in the myelodysplastic syndrome. This type gives no response to pyridoxine. The secondary causes may be defects in the pyridoxine, the cofactor of ALA synthase, or maybe the mitochondrial toxicity. Defects in the pyridoxine may be caused by its deficiency or pyridoxine antagonists as the anti-TB drug isoniazid. Mitochondrial toxicity may be caused by either disease or drugs. Diseases include copper deficiency, carcinoma, myxedema, and hematological malignancies. And drugs include chloramphenicol and lead. Pathogensis was illustrated as a defect in the heme synthesis caused by defect in the ALA synthase enzyme. This effect leads to iron precipitation in the mitochondria, which causes mitochondrial damage. This causes further deficiency of ALA synthase enzyme and further defect in the heme synthesis and so on. Clinically, patients are presented by manifestations of anemia early in life, which is mostly combined with a spinocerebellar ataxia. As it is an X-linked disease, it is expected to be more common in males. However, citroplastic anemia is common in females as a result of more lionization of the normal X chromosome in females. Laboratory diagnosis. The CBC in these patients shows microcytic hypochromic anemia. The blood film will show what's called dimorphic picture, which means presence of different percentage of hemoglobinization of RBCs, or the presence of both hypochromic and normochromic RBCs. Also, there will be anisocytosis due to the presence of both macrocytic and normocytic RBCs, or due to the presence of both macrocytic and normocytic RBCs in cases of myelodysplastic syndrome. A common complication of the disease is the hypersplenism, which will be reflected in the CBC by leukopenia and thrombocytopenia. After splenectomy, the post-splenectomy film will be offered in the form of siderocytes, normoblastemia, macrocytosis, basophilic stippling, and the presence of RBCs inclusions. Reticulocytic count is less than expected from the degree of anemia due to the ineffective erythropoiesis or the intramedullary destruction of the RBCs, precursors, and reticulocytes. Iron profile is indicated to differentiate the microcytic hypochromic anemia. Here, there will be iron excess as iron find no protoporphyrin to incorporate with. There will be high iron, high ferritin, high transferrin saturation, and low TIBC. Bone marrow is hypercellular with erythroid hyperplasia in the form of decreased or reversed ME ratio. Erythroplasts are microcytic with a vacuolated cytoplasm as a result of the heme defect. Iron stain shows increased hemosiderin in the macrophages and increased percentage of citroplasms, increased siderotic granules. Here, siderotic granules have a special distribution around the nucleus, giving the picture of a ring. And these sideroplasts are called ring sideroplasts. Free erythrocyte protoporphyrin will be low as I have a defect in the protoporphyrin synthesis. There is an exception of the type caused by a defect in the ATP binding cassette where there is no low free erythrocyte protoporphyrin. The differential diagnosis includes the differential diagnosis of microcytic hypochromic anemia. The key of diagnosis is in this type of anemia is the iron profile. Here, there is high serum iron, high serum ferritin, high serum transferrin saturation, and low serum TIBC. Bone marrow iron stain will show the characteristic ring sideroplasts. Here, the electrophoresis or the hemoglobin electrophoresis will be normal. Differential diagnosis also includes the differential diagnosis of the dimorphic picture or the double population of RBCs in the blood film, which may also present in cases of iron deficiency taking iron supplementation, where you will see the iron deficient RBCs together with the iron non-deficient ones as a result of starting treatment. It occurs also in thalassaemic patients after blood transfusion, where you will see the thalassaemic RBCs together with the transfused normal RBCs. Also, if iron deficiency is combined with vitamin B12 deficiency, you will see the iron deficient macrocytic RBCs together with the vitamin B12 deficient macrocytic RBCs. Differential diagnosis also includes the differential diagnosis of the ring sideroblast, which may be found in idiopathic myelofibrosis and acute myeloid leukemia, especially the M6 and causes associated with multilineage dysplasia. Treatment includes supplementation with vitamin B6 or pyridoxine and folic acid. Patients may need blood transfusion with iron chelation to remove the excess iron. Is the splenectomy indicated for these patients? The answer is no, as the splenectomy has no role in the correction of anemia. Also, splenectomy has complications as thrombocytosis and infection. Lead poisoning is related to somewhat to the citroplastic anemia. Lead poisoning is the accumulation of lead in the body leading to toxicity. It is more seen in workers of the battery industries and workers who use paints. Lead inhibit both ALA synthase enzyme and the ferrochelatase enzyme, leading to sideroblastic anemia. It also inhibits the globin synthesis. It causes denaturing of RBC's membrane proteins, leading to hemolysis. It also inhibits the pyrimidine 5' nucleotidase enzyme, which normally break down the remnant of RNA present in RBCs. The inhibition of this enzyme causes deposition of RNA remnants in the RBCs, causing basophilic stapling. Clinically, lead poisoning may be asymptomatic or presented by headache, abdominal pain, renal failure, tingling, insomnia, delirium, cognitive defect, tremors, hallucination, and even convulsions. Laboratory diagnosis of lead poisoning includes CBC, which may show hemolytic anemia in the form of normocytic normochromic anemia with reticulocytosis. Blood film will show the basophilic stapling resulted from the precipitation of RNA remnants in the RBCs due to the inhibition of the pyrimidine 5' nucleotidase enzyme. Siderotic granules may be seen in RBCs if there is a defect in the splenic function. As there is hemolysis, there may be reticulocytosis and normoplastemia. Bone marrow will show hypercellular bone marrow, erythroid hyperplasia, decreased or inverted ME ratio, microcytic vacuolated normoblasts, increased hemosiderin in both macrophages and sideroblasts, and will show also the ring sideroblasts. The serum iron is high. Lead is high in both serum and urine. Intermediates of protoporphyrin may increase in RBCs as coproporphyrin and the protoporphyrin. The latter increases as a result of the inhibition of the ferrochelatase enzyme. Or in urine as ALA synthase, coproporphyrin, and uroporphyrin 3. Porphyria is another defect in the protoporphyrin synthesis, which is present in very few cases around the world. It is caused by blockage of the protoporphyrin synthesis in the middle of its pathway, causing accumulation of intermediates of this pathway, which are hepatotoxic and cause hemolytic anemia and photosensitivity. Look at this picture. Porphyria was known as the legend of the wolfman, which is known as some people who uses to live in darkness and known as vampires or bloodsuckers. Porphyria patients have photosensitivity and prefer to live in darkness because the sunlight causes burns to their skin. Also, these patients can't synthesize heme. They try to get the heme ready-made. This forces them to drink raw blood or eat raw liver to get more and more heme, and thus the name of the ligand, the vampire or bloodsucker. Also, the accumulation of the protoporphyrin intermediates causes their tusks to enlarge and give fluorescence under the ultraviolet rays. All these participate in the full picture of the ligand. According, porphyria is a defect in the protoporphyrin synthesis, leading to accumulation of the intermediates of protoporphyrin, which causes photosensitivity, GIT symptoms, nervous system symptoms, hepatic symptoms, and dermal symptoms. It is classified into two large categories, hepatic and erythropoietic porphyria, which are further classified. Here is the pathway of protoporphyrin synthesis, illustrating the enzyme utilized in this pathway and the intermediates of this pathway. We said that protoporphyria is classified into hepatic and erythropoietic porphyria. Erythropoietic porphyria is classified into congenital erythropoietic porphyria and erythropoietic protoporphyria. Congenital erythropoietic porphyria is caused by defect in the uroporphyrinogen 3 co-synthase enzyme, leading to accumulation of the porphyrinogen. While erythropoietic porphyria is caused by defect in the ferrochelatase enzyme, leading to accumulation of the protoporphyrin. The hepatic porphyrias include acute intermittent porphyria, hereditary coproporphyria, porphyria variegata, and porphyria cutanea tarda. Acute intermittent porphyria is caused by defect in the porphyrinogen deaminase enzyme. The hereditary coproporphyria is caused by defect in the coproporphyrinogen oxidase enzyme. Porphyria variegata is caused by defect in the protoporphyrinogen oxidase enzyme, and porphyria cutanea tarda is caused by defect in the uroporphyrinogen decarboxylase enzyme. These patients suffer from hemolytic anemia and disfiguring cutaneous lesion. All these effects are caused by accumulation of the protoporphyrin intermediates, either in the skin, in the liver. Diagnosis is made by measuring these intermediates in plasma, urine, or red cells. Management depends on the avoidance of sunlight. Also, beta carotenes decrease the photosensitivity in these patients. These patients may need blood transfusion but must be accompanied by iron chelation. Patients with erythropoietic porphyria, especially the erythropoietic protoporphyria, should avoid the occurrence of iron deficiency because iron deficiency increases the accumulation of free protoporphyrin and its intermediates, increasing their manifestation. In some patients, splenectomy may increase the RPC's survival. Now we had finished disorders of the heme, including disorders of iron and disorders of protoporphyrin. I hope these lectures was interesting to you, and I hope you understand this field. See you soon. God bless you. Wassalamu alaikum wa rahmatullahi wa barakatuh.